Hi, I'm Lucy Drummond. I'm a Junior Clinical Fellow at the Western General Hospital, and I'm going to present our worldwide study into the dosing, administration and protocolisation of intravesical gentamicin. Our study looked at the intravesical use of gentamicin in the treatment of recurrent urinary tract infections. We'll talk about our specific aim, the mechanisms of action of gentamicin, describe how we designed our study, and present our results looking at how we can produce a protocol for mainstream usage. Intravesical gentamicin has long been proven to be an effective option in the treatment of recurrent urinary tract infections. It's particularly good in those patients with infections caused by multidrug resistant organisms. As it's administered locally, it tends to be better tolerated by patients as there are fewer systemic side effects. Importantly, especially relevant in the COVID era, it can be administered by patients themselves. This can be beneficial for a plethora of reasons. It shifts the patient's locus of control to an internal locus of control, allowing the patient to take increased responsibility for their treatment. This can then harbour further positive patient actions, such as ensuring good hydration, meticulous hygiene, post-culture avoiding, and ensuring regular bowel habit. Of course, having this patient administered also reduces trips to hospital or healthcare facilities and allows treatment to continue unaffected by a global pandemic. Being patient administered also reduces strain on clinician time. However, there do remain options for those patients not able to self-administer, perhaps those that lack dexterity or their home situations don't allow. This can be nurse-led, which again still protects senior clinician time. Despite these benefits though, the use of intravesical gentamicin remains sporadic and there's no consensus for its administration, whereas intravenous gentamicin use is well regulated, with hospitals routinely using protocols, be it a gentamicin calculator or a 3 or 5 mg per kilogram regime. There is no such uniformity with the use of intravesical gentamicin. So we set out to investigate the current usage of intravesical gentamicin and to draw upon the experience of experts in order to construct a robust consensus protocol. 90% of urinary tract infections are caused by E. coli, a gram-negative aerobic bacterium. Gentamicin is an aminoglycoside antibiotic which has a bactericidal activity, that is to say, at appropriate concentrations it acts to kill bacterium. Gentamicin is effective against gram-negative infections such as those caused by E. coli. It enters the cell through an oxygen-dependent manner via active transport. Therefore, it is effective against aerobic bacteria. Once in the cell, it binds to the 16S ribosomal RNA at the 30S ribosomal subunit. This disrupts the translation of messenger RNA, leading to the formation of truncated or non-functional proteins. Gentamicin performs concentration-dependent killing. Therefore, at higher concentrations, it is associated with greater antimicrobial killing. Therefore, when administered intravenously, concentrations require monitoring. It is primarily renally excreted, and common side effects include nephrotoxicity and ototoxicity. Importantly, it has been shown time and time again that intravesical administration shows no detectable level of gentamicin in serum. So how did we construct our survey? Well, using an online platform, we distributed a 10-question survey to members of the International Continence Society and the Scottish Pelvic Floor Network, and we received responses from clinicians in all corners of the world, from the UK to Australia and from South America to the Middle East. This is the survey that we distributed. Of the 40 clinicians who responded, 26 use intravesical gentamicin for recurrent urinary tract infections, and a further 5 use it for both recurrent urinary tract infections and as prophylaxis during routine catheter changes. Therefore, 31 centres in total reported experience with intravesical gentamicin usage. Of the 9 centres who do not use this therapy, expense was cited as the most common barrier. Of the 31 respondents using the treatment, 74.2% report it being administered by the patients themselves, with 25% utilising a specialist nurse or district nurse for administration, and some centres of course offering more than one option. Dosing regime varied dramatically, from a dose of 12 milligrams right up to a dose of 240 milligrams, and from a frequency of twice daily to once weekly. The most commonly used dose, however, was 80 milligrams in 50 ml of saline, and this was administered once daily. 90% of centres used intermittent self-catheterisation to administer the antibiotic, whilst the remainder used indwelling catheters. 2/3, so 67.7%, reported no complications at all, whilst 13% observed resistance as a complication. Intravesical gentamicin has been shown to be an effective and well-accepted treatment option throughout the world, with expert experience revealing very few complications. So given that it's well tolerated, it can be protocolised, and it can be patient administered, it ought to be brought into mainstream practice. Although currently there lacks a blanket policy on its use, we've now shown that the consensus opinion within expert hands is the use of 80 milligrams of gentamicin and 50 ml of saline, administered once daily via intermittent self-catheterisation. Shifting the paradigm to patient administration empowers patients to become more invested in their treatment. It frees up clinician time, and it reduces the number of hospital attendances. Intravesical gentamicin ought to be more widely used, and in bringing together this expert experience from across the globe, we have shown that protocolisation is indeed possible. Moving forwards, we would construct and distribute a protocolised regime, inviting centres to draw upon this consensus opinion. We would also look to investigate the patient's perspective and find out what they find challenging about its administration. Many thanks for your time.